Hello, everyone. My name is Gibran, and I'm a clinical research fellow in Pericardial Disease Center at Cleveland Clinic. Today, we will be discussing about the pericardial tensions, unmasking clots, masses, and effusions. So the patient was presented in outside hospital, a 56-year-old male who was a former smoker with no past medical history. He presented with compressive mid-sternal chest pain for 4 hours before presentation, which were exacerbated by deep breaths in changing positions and is relieved by sitting upright. He denies any lower limb swellings, chill, sore throat, or cough. He reported 1 episode of diarrhea on the same day. He also reported a chest trauma 1 month ago while opening a malfunctioning door and hitting himself. So the blood pressure was 102/73. His SpO2 was normal. Generally, he looks very uncomfortable when he was taking deep breaths. Labs were unremarkable. The presenting ECG, there was ST elevations. And echo on the outside hospital, the echo was reported, but there was no images available. It was narrated as there was a moderate to large circumferential pericardial effusion, and there is no echocardiographic evidence of tamponade. So the patient was discharged from the outside hospital and was on colchicine, prednisone, and ibuprofen, and was told to follow up with a cardiologist with an echo in 1 month. So the patient came. This time the patient was asymptomatic. Vital was good, except the blood pressure was slightly low. Physical examination was unremarkable. After reviewing his echocardiogram, his cardiologist advised him to be admitted. This was his echocardiogram. And if we see here, this is the pericardial effusion in both the cases. And this is a CT of chest showing pericardial effusion as well. So at this time, when we see a pericardial effusion, everyone will have to go for like a pericardiocentesis, and that's what they did. They did a pericardiocentesis, and there was 300 ml of blood effusion drained, followed by a 50 ml in the next 48 hours from the pericardial drain. So at that time, they thought that the effusion was the main problem, and they drained the effusion, and they told the patient to go, and the pericardiocentesis analysis was done. There was only RBCs that was elevated, and it was negative for malignant cell. So at this moment, when the patient was with outside hospital, they said, okay, there is no negative malignant cells, and now it's like a pericardial effusion, and now we have drained the pericardial effusion, so the patient is good to go. But post-pericardiocentesis echo was done, and now if we see after pericardial effusion has been drained, there is a slightly like a solid mass or something. Here and right here.
That was there before, when the effusion was there.
Yes, but it was at that time. It was not picked up by at the echo lab at the outside hospital. They thought it's maybe just an effusion. They just went for a pericardiocentesis, and it is very clear when the pericardiocentesis has been drained. But making sure that the patient has a history of trauma to the chest, and at this time they may have thought there will be a hemopericardium there. So but after pericardiocentesis, it was very visible on the echo. But at that time, there was no diagnosis made on that time. So cardiothoracic team was evaluated, mentioned this was likely a clot or hemopericardium along the left atrium, as because he has a history of chest trauma. Advised to undergo an outpatient cardiac MRI and follow up in the pericardial clinic. He was discharged on colchicine, prednisone, and tapering of ibuprofen dosing. The patient presented to the outside hospital emergency department with complaints of coughing up blood, flank pain, and chest pain. Underwent CT-PE showing segmental PE in the right upper lobe and a large opacity encasing the heart, resulting in compression of the superior vena cava, PA branches, pulmonary veins, and the left atrium. Anticoagulation was held due to concerns of hemorrhagic pericardial effusion, and the patient was ultimately scheduled for a pericardial window with a video-assisted thoracoscopy surgery, but patient requested to transfer to the CCF main campus for further management. So this is when he presented to the Cleveland Clinic. He was put on 4 liters of oxygen. He was actively coughing up blood. He was tachycardic. The CRP was 2.3. The ultrasensitive CRP was about more than 300. ESR was 60. The BNP was 2,876, and this was the echo when he presented to the Cleveland Clinic. So the mass is still there. And then the patient was transferred to CICU with having worsening of shortness of breath with HNFC of 50 liter flow rate and 50% FiO2. His blood pressure is slowly dropping, currently 101, and after 1.5 liter of intravenous fluids, but has sinus tachycardia in the 110s. So he has a minimal pulmonary reserve and receives significant intravenous fluids at this point. Potential rapid sequence intubation in the ICU may drop further preload in the precarious setting. There was no percutaneous drainage or window option since the clot appears solid and posterior. Discussed with the CTS staff, the cardiothoracic team staff, and patient was taken for emergent sternotomy, pericardectomy, and hemopericardium removal and washout. So this is the pre-evacuation intra-op echo. We can see the mass here. At this time, they were still thinking about that this is, before they were thinking about this is a hemopericardium or like a clot. This is the post-evacuation intra-op when the mass was removed. So we can see the echoes very clear. I don't know why this is. Okay, so brief post-op course, the emergent interior pericardectomy and organized pericardial mass extraction was done. The patient completed antibiotic, and eventually back to the regular activity and normotensive, and the pericardial mass was sent for pathology. So this was the resolution echo 2 weeks later. So when the mass was sent for pathology, it came back as a myxoid pleomorphic liposarcoma. So it started
Can you go back? I mean, there's still a mass there. I mean, it's significant in the right panel, so it's not like everything is resolved.
Okay, but here?
Yeah.
Okay. But maybe this was the echo. Okay. But it started from pericardial effusion, and then they thought it's a hemopericardium or a clot. But eventually, when the pathology was sent and it came back, it shows as a myxoid pleomorphic liposarcoma. And it was treated, so basically the treatment of pericardial myxoid pleomorphic liposarcoma involved a multimodal approach to aggressive nature and extreme rarity of this subtype. The primary treatment modality is surgical resection with the goal of achieving clear margins, as compared to surgical excision and critical for local control and potential cure. Radiotherapy is often employed as an adjunct to surgery. Chemotherapy may be considered particularly for high-grade and unresectable tumors. The follow-up oncology is that post-op PET without metastatic, there were no metastasis, currently undergoing radiation plus systemic therapy with doxorubicin and ifosfamide. Thank you.
Okay, any questions? Last few minutes of the course. Craig, any comments on a weird mass in the chest? Must be a run of masses at Cleveland Clinic. Wow. Okay.
The only thing I'd say is that it's, they thought it was a hemopericardium, but it's posterior.
Yes.
And that's a very unlikely scenario to use that as an explanation. You'd expect more anterior, usually the right ventricle.
Okay. And even in the first echo, when it was presented to the outside hospital, when the pericardial effusion was present, even the mass was still very visible at that time. But I don't know why it was missed.
So one other point I'd like to mention, I learned from experience, you have to be very careful sticking needles into pericardial fluid with a mass. I had one bad experience of a young person that had an MI after doing that. Drained the fluid, and then because of the mass, we didn't know what the mass was, everything shifted and the LAD got compressed, so it caused an MI from the centesis. So even though it could drain, but if you see a mass, I would be very nervous in terms of just poking a needle into that, unless it's life-threatening. But so you have to be very, very careful with this, especially, we didn't know what it was, but bad outcome.